Good morning, everyone, and welcome to our webinar, De-Prescribing in Advanced Illness. My name is Lauren Blair, and I am the Community Relations and Development Manager at Coastal Hospice. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Tidal Health, Atlantic General Hospital, Worcester Commission on Aging, the VA, Shore Regional Cancer Center, Talbot Hospice, and many more. It's wonderful to see all of you. Before we begin, allow me to go through a few housekeeping items. Continuing education disclosures will be listed on the screen. You may see myself or my colleagues Alejandra, Joy, or Lauren pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time should we have any. I will also come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Please feel free to type any questions in the chat box, and we will answer questions at the end of the presentation. It is my pleasure to introduce our presenter today. Dr. Lynn McPherson is Professor and Executive Director of the Advanced Postgraduate Education and Palliative Care in the Department of Pharmacy Practice, Sciences, and Health Outcomes at the University of Maryland School of Pharmacy in Baltimore. She is the Executive Program Director of the online Doctor of Philosophy and Master of Science in Graduate Certificate Program in Palliative Care at the University of Maryland. In addition to a PharmD degree, Dr. McPherson has a master's degree in Instructional Systems Development and a master's in Distance Education and E-Learning. Dr. McPherson has maintained a practice in hospice, both local and national, throughout her entire career. Dr. McPherson is particularly interested in the safe and effective use of medications in patients with life-limiting illness, ranging from drug selection, de-prescribing, and risk mitigation. Dr. McPherson developed the first palliative care pharmacy residency in the U.S. She has won numerous awards for teaching and for her innovative practice in end-of-life care. She has published numerous articles, chapters, and 5 books, including the second edition of the best-selling Demystifying Opioid Conversation Calculations, a guide for effective dosing. Welcome, Dr. McPherson. Thank you so much for being here with us today, and I turn it over to you.
Wonderful. Thank you, Lauren, and a good day to everyone. Good afternoon. This is one of my favorite topics to talk about in the world is de-prescribing. You don't see many pharmacists who are just as or more interested in stopping drugs as starting medications. Okay, here's the information about disclosures. I'll leave you to read that. And these are my learning objectives for our hour together. We're going to talk about a systematic approach to de-prescribing in people living with an advanced or a serious illness. And we're going to use 2 exemplars. We're going to look at metabolic syndrome and Alzheimer's disease. And last, we may talk a bit about the benefits and burdens of anticoagulation in those with advanced illness. So let's put you all to work right away. So what the heck is polypharmacy and why should we care about it? So first, what is polypharmacy? Is it a patient taking 2 or more medications concurrently, 5 or more, 9 or more? Or as one of my pharmacy students said a year ago, she thought polypharmacy was a patient who uses 2 or more pharmacies. So I'm sure opinions are all over the place, but actually the answer is B, taking 5 or more medications. So how prevalent is polypharmacy in our world today? So if you look at the US, from the year 1999 to 2000, it was about 8.2% of people were receiving 5 or more medications concurrently. If you look at a little bit more than a decade later, it pretty much doubled up to 15%. So goodness knows what it is right now, even another decade beyond that. And I think it also depends on the setting. So if the patient is in long-term care, 91% are getting 5 or more drugs, 74% 9 or more, and almost 2/3 are getting 10 or more medications per day on a regular basis. No wonder they're all constipated from the fillers in those drugs. So what are the consequences of polypharmacy? Well, I don't think this is surprising information. All those medications, while certainly they are life-saving medications, absolutely, but they can lead to frailty and dementia, certainly cognitive decline, disability, hospitalization, and sometimes increased mortality. So it's important that we keep an eye on the medication regimen and make sure that we right-size it, the Goldilocks approach, all the time. So the consequences of polypharmacy at the end of life are even higher. So when we look at a medications regimen for a patient who is at the end of the road, they often have a tremendous anticholinergic burden. So that's the dry mouth, blurred vision, constipation, urinary retention, and delirium. An enormous sedation burden. We use opioids and benzos and antipsychotics and antidepressants. So we see a lot of sedation. And on top of age-related, we also have disease-associated changes in pharmacokinetics and pharmacodynamics. So how does the number of medications patients take as they near the end of life compare with patients in a similar age bracket who are not at the end of the road? Is it the same? Is it more? Or is it less? So inherently, you would think it would be less, wouldn't you? Well, let's take a look. So Morin et al. Reconstructed the med regimens for the previous year of over 500,000 adults who died in Sweden between 2007 and 13. And the average results that showed in the year before death, the percentage of patients taking 10 or more increased from 30% to 47.2%. Another retrospective study of over 500 people in a nursing home in Sydney evaluated changes in the prescribing of symptomatic and preventative drug therapy in the last year of life. So it really didn't change a whole lot. So symptom management medications increased a little bit, which you would certainly expect as we're treating pain and nausea and so forth. And disease prevention medication use decreased a little bit. At the time of death, a third had actively prescribed antithrombotic agents, antihypertensives, and here's the kicker, osteoporosis medications. This just in, you can go to heaven with less than perfect bone density. And this last one just kills me. 179 patients in the last week of life in the hospital, hospice, or home in the Netherlands. They looked at the mean number of medications used per patient. In that last week, it was 9 on day 7 before death. And this last statistic just blows my mind. 30% of these people received a dose of a preventative medication on the day they died. What are we trying to prevent? So if polypharmacy is the problem, what is the solution? Well, there are lots of words for this. It used to be called the geriatrician's salute, de-intensification, and now we talk about de-prescribing. I actually prefer to talk about goal concordant prescribing. Certainly, we work very hard to elicit the patient's goals of care. So our prescriptive patterns ought to be consistent with the patient's goals of care. So how do we define de-prescribing, though, which is the same as goal concordant prescribing? It's defined as the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. There's a lot in that definition, but I think you would agree every aspect is exactly appropriate. So again, I like goal concordant care and goal concordant prescribing. So what do surveys show about patients and their family members, caregivers, as well as prescribers? This is one survey looking at community dwelling older adults living in Canada. 80% or more strongly agreed, I'm okay with the number of drugs I'm taking, although half thought I'm taking kind of a lot of drugs, and half said they would like to reduce the number, and 75% said I would be happy to stop one or more if my doctor said it was okay. But also 80% said they would take more if their doctor thought it was necessary. A survey in Australia in old age homes said 40% wish they could stop one or more drugs, but this bumped up to 80% if their doctor agreed this was a good idea. Survey of older adults in a teaching hospital in Sydney, 90% again said they would be happy to stop one or more if their doctor agreed, and 95% were willing to discontinue their statin, although a similar number were concerned about statin side effects. Interestingly, if you look at the data from Jean Kuttner, very few people, when you look at the big study that she did of people who were within a year of death, thought that, by stopping my statin now, does that mean I wasted all that time taking the statin? And very few people thought that was correct. And probably the biggest study is by Emily Reeve, looking at Medicare beneficiaries in the US, surveyed about de-prescribing, surveying about 2,000 people. And again, 92% strongly agreed. If my doctor said it was possible, I am more than willing to stop one or more drugs. And I really would like to reduce the number that I'm taking. 2/3 thought that was correct. What about prescribers? What do they think about this? 160 doctors in Parma were surveyed. 75% said, I'm pretty confident in my ability to de-prescribe, including preventative medications. 53% were comfortable stopping guideline recommended medications. So you can see a little bit higher level of discomfort in doing that. And it gets worse when it's a medication prescribed by another physician, particularly a specialist. So for example, maybe a primary care physician is reluctant to stop a medication that a cardiologist started, for example. 45% felt uncomfortable stopping a drug where the patient or caregiver thought it was important to continue. I know that it's a challenge sometimes to discuss stopping medications or changing medications on a patient who is end of life for hospice or palliative care. Often, many times, it's the family member who is more resistant than the patient themselves. So I'm a big believer in having an evidence-based conversation in those situations. General practitioners in Australia said they felt pretty comfortable doing this, although primary care doctors said, you know what, this de-prescribing feels like I'm swimming against the tide. It's not a popular thing. For one thing, we are taught to prescribe. We are not taught to de-prescribe. And patients certainly have expectations. I mean, if you look at the literature of patients who go to see their regular doctor and the every 3-month thing, if they've got some complaint or report or something new, they want to leave with a prescription in hand. So that's the expectation that medications fix things. And goodness knows we're all supportive of better living through chemistry, but their expectation is not to stop medications. And also there are certainly organizational constraints. When you look at the average length of time a provider has with a patient in primary care, it is very, very brief. We see fragmented care, and often we cannot get access to expert guidance. And the last 16 general practitioners in Denmark, the themes of barriers to de-prescribing, again, lack of interprofessional communication, patient, and I would say family not on board, and the culture of encouraging the use of medications and not de-prescribing. So how do we go about doing this? And I think this is an important slide, and I'm going to go over each in greater detail in a moment. But really, there are 3 different approaches to this. One is the model or framework, which is kind of a way of thinking about the whole gestalt of de-prescribing. The next is looking at the patient's entire medication list and thinking about things about the patient and things about the drugs. And the last is looking at specific medications or medication classes. So let's explore this. So this model or framework is this high-level cognitive function of making medication decisions for people with a limited life expectancy. So it's sort of like, you're just shifting your mindset from prescribe and fix things and so forth to considering the whole picture here. So how long does it take? If I start a new medication, how long does it take to see benefit? Well, if it's an antibiotic, maybe by the next day. If it's a corticosteroid, maybe 24 to 48 hours. If it is a statin for secondary prevention for heart attack, actually takes about 2 years for those curves to separate, those treated and those not treated. So you have to consider, will the patient likely be gone before this medication brings any benefit to the table? So what is the patient's life expectancy? Most importantly, what is the patient's goal of care? And will a medication achieve those goals for the patient? This is a multi-step, person-centered approach, and we're all about, person-centered outcomes. Includes comprehensive assessment of the patient's clinical status, diagnosis-specific status, and medications with the goals of care and shared decision-making incorporated at every step. So we are very careful in having these conversations with patients and families to consider the patient or family's point of view. And we'll look at those 2 examples. And I think one of the most valuable things we can do is provide more information and educate patients and families so that we can all make a joint informed decision. So looking at the entire medication list, we have many tools that will do this. So tools that outline approaches to identify and prioritize drugs for de-prescribing. The tools include general principles to use when evaluating a whole medication list. So looking at, for every medication, for every patient at any stage of life, we always look at the risks and the benefits of a medication before we start it, while they're on it. Considering whether it's likely to help a patient achieve their goal of care, and consider the burden of treatment. Some medications have a lot of toxicities, or they're kind of a pain in the neck to administer. And many of these tools have a stepwise approach or an algorithmic approach. Certainly everybody has heard about the Beers list, which was developed by Dr. Mark Beers. Certainly it is promulgated now by the American Geriatric Society, where it's a whole list of medications that we should think twice about older adults. But I will say, sometimes there are items on the Beers list that are at odds with someone who is actually end of life. So I actually really like the Stop Frail tool, which is a screening tool of older persons' prescriptions in frail adults with limited life expectancy. That's one of my favorite tools. And there's one called D-Farm as well. Here's an example of the stop frail 2. They break all the medications down into these pharmacologic categories. So A is general. So any drug that a patient is not taking consistently, or there's not a clear indication, or the symptom is now resolved. Often during a hospice team meeting, I will ask the nurse case manager, why is this patient on this medication? And it's not enough to say digoxin is a heart pill. Yes, I know digoxin is a heart pill. I'm a pharmacist. Why is this patient on digoxin? Is it for heart failure? Do we really need it? Is it for an atrial arrhythmia, for example? So what is the scoop with that patient? And then it breaks it down into cardiology, coagulation, so forth and so on. So they have guidance for each of these categories. And then the third is medication-specific tools. This is very helpful. So this is a website I'm very fond of, De-Prescribing.org. And they have, 5 or 6 or 7 things just as shown here on this slide, tools that provide more detail on how to approach de-prescribing. Like, when do you do it? How do you do it? What do you monitor? What are the benefits? What are the harms? So they've got this kind of a card, which you could certainly print out. You could even laminate it, carry it around in your pocket. They have it for proton pump inhibitors. The one depicted here is anti-hyperglycemics, antipsychotics, the benzodiazepine receptor agonists, so the benzos, and one of my favorite, my all-time favorite, is the cholinesterase inhibitors and memantine. So let's look at 2 examples. We're going to start with metabolic syndrome. So what the heck is metabolic syndrome? Well, I think half our country has it. It's a cluster of risk factors that raise the risk of heart disease, diabetes, stroke, and other health problems. So according to the American Heart Association, about 1/3 of all adults have metabolic syndrome, and I think that's a bare minimum there. So if we can diagnose the patient with 3 of the following risk factors, it's said that they have metabolic syndrome. So according to the National Cholesterol Education Program, 3, metabolic syndrome is defined as central obesity, so defined by the waist circumference. So if somebody is built more like an apple than a pear, the apple is at greater risk for metabolic syndrome. Plus 2 of the following 4 factors: increased triglycerides or being treated for hypertriglyceridemia. And isolated hypertriglyceridemia is very much a reflection of diet. So often if you just tell somebody, no, you cannot drink 6 bottles of Coke a day, knock it off, or a huge bottle of orange juice every day, just knock it off. You'll see that come down very nicely. Or it could be a reduced HDL cholesterol, which is our good cholesterol. So we'd like it to be 50 or 60 if possible, or they're being treated for a low HDL. Increased blood pressure or treatment thereof, or raised fasting plasma glucose, or previously diagnosed diabetes. So let's meet our patient, Mr. Herndon. He is a 76-year-old man admitted to hospice with stage 4 non-small cell lung cancer. His prognosis is about 4 to 6 weeks, according to his oncologist. He has comorbid conditions of type 2 diabetes, high blood pressure, chronic kidney disease, dyslipidemia, and he has an 80-pack year history of smoking. He stopped a year ago when he was diagnosed with lung cancer. So here's his medication history. He's been taking atorvastatin for his dyslipidemia for over a decade, metformin for his diabetes, Lantus insulin at bedtime, and sliding scale Novolog 4 times a day, a rapid-acting insulin, lisinopril and amlodipine for high blood pressure, and goodness knows we all have to take a multivitamin with iron right up to the last day we die, right? Once a day for general health, acetaminophen, the extended release 650, so 2 of those, or 1,300 every 8 hours for pain, long-acting morphine 30 Q12, Roxanol, the oral morphine solution, 10 milligrams every 2 hours as needed, and Senna because the opioids cause constipation. So Mr. Herndon is 5'10". He weighs 165 pounds, and he has lost 100 pounds since his diagnosis. At this time, his waist circumference is 34 inches. He is being a doobie, and he checks his blood sugar 4 times a day, but he rarely, if ever, uses that sliding scale Novolog insulin. As a matter of fact, he complains of hypoglycemic symptoms occasionally. Now, we're generally not going to draw labs in hospice care, for example, with chronic disease states, but his A1C 6 months ago was 6.9. But on admission, the nurse notes that his blood pressure is 120/70 when he's seated, and when he stands up, he gets woozy, he gets kind of dizzy. When you suggest slimming down his medication regimen, Mr. Herndon gets very upset and cries, "What? My heart doctor and my regular doctor said I had to stay on these medications till the day I die. Are you saying I'm going to die tomorrow? You young whippersnappers always want to upset the apple cart." So my young whippersnappers, what do you say to this one? Well, let's look at these medications individually. So when I look at a list like Mr. Herndon's list, I'm like, oh, good grief, let's get rid of the multivitamin with iron. But you know what? I have bigger fish to fry right now, looking at his medication regimen. So if he feels strongly the multivitamin with iron is keeping the wolf from the door and it's not causing any problems, I'm not going to have that discussion right now. I'm fine letting that go. As a matter of fact, if he has a prognosis of 4 to 6 weeks, it'll probably get to the point where he is not comfortable swallowing it and it'll fall off by attrition. But I do worry about the iron and the vitamins and minerals. They're probably increasing his risk of constipation. And we know that these vitamins and minerals can cause nausea themselves, or if it causes or worsens the constipation, constipation can cause nausea as well. Also, the iron can turn his stools dark. It can make us, it's difficult to determine, is he bleeding internally? We'd have to do a guaiac, but that's pretty unlikely. So let's throw him a bone with the multivitamin with iron. All right, next, his analgesics and his laxatives. So this is really interesting. I know that in the Scandinavian countries, when someone is diagnosed with cancer and they have pain, everybody and their mother is put on acetaminophen 4 grams a day. End of discussion. They could be on 8 million milligrams of morphine a day, and they've still got that 4 grams of Tylenol cooking. So what's with that? So studies have shown repeatedly. So I remember years ago, one of my residents investigated this and did this is his pharmacotherapy presentation. And he looked at like 3 or 4 studies that evaluated this. This is probably 15 years ago. And they did show that once somebody is taking about 40, 50 milligrams a day of oxycodone, which is about 60 to 70 of oral morphine a day, those patients could not tell the difference with or without the acetaminophen. And this study was actually repeated several months ago and just published, and the data was very much consistent. So I think you have to look at what are the patient's wishes. If the patient very much feels that the acetaminophen is helping, and I will say once in a while, we'll have someone with severe pain due to their terminal diagnosis, but maybe they also have a headache. And the acetaminophen is not really helping the pain from their terminal illness, but it might be helping that headache. So that's a horse of a different color. I would consider it. But I also look at, does the patient have liver disease? Does the patient have a history of alcoholism? Because that will put them at much greater risk. How about the morphine? Is the morphine getting the job done? So if his pain is not at goal, we need to reevaluate, are these the best medications to treat his pain? And the Senna, of course, is a stimulant laxative. Is it maintaining normal bowel function for this patient? So we would have to assess the patient before we decide on these medications. So I think, again, I mentioned this earlier, the words of the day are time to benefit and the legacy effect. So the time to benefit of a medication is defined as the time to significant benefit observed in trials of people treated with the drug compared to control. So at this critical time with Mr. Herndon, 4 to 6 weeks left to live, we certainly want to pick medications that are going to give benefit pretty darn quickly. So morphine is going to work within the next couple of hours. So that's pretty quick onset. So we have to be mindful of that. There also is a legacy effect. A legacy effect, I always think of the post-antibiotic effect, which means even if you've been taking a drug and you stop it, you're still receiving benefit from having taken that medication. And many medications have a legacy effect. And I think this is so important that we be knowledgeable about these so we can educate the patient and the family. So let's look at the other elements of his metabolic syndrome. What is hypertension? Well, the silent killer. So what's the goal blood pressure? Well, it depends on who you ask. So the American College of Cardiology Heart Association in 17 said less than 130/80, including people over 65 who are ambulatory and community dwelling. The European group said less than 140/90. The UK NICE guidelines say less than 150/90 for fit patients 80 and older even. And then less than 150 for people over 60 or less than 140 with a history of a stroke or a heart attack. So the time to benefit in treating hypertension is 2 to 5 years. So it takes 2 to 5 years to see a reduction in the risk of having a heart attack or a stroke that is related to hypertension. Now, what is the legacy effect? This is a beautiful thing here. 37% of patients remain normotensive 6 months after withdrawing therapy, and the effect persists in a full quarter of patients treated at 2 years. So this is wonderful news. So we can say to the patient and the family, your blood pressure is controlled right now. I think we should maybe taper down on the antihypertensives, see how you do, because we do know that almost half of people this blood pressure control will persist. And then when you put on top of that, we know that our blood pressure in later years starts to decline, regardless of whether or not we're being treated. So, but we do have to be mindful of, it may be that, he's not having any adverse effects, so we could take our time tapering down and so forth. But is the patient having any orthostasis, hypotension, syncopal events, or falling? Also, just a word about prescribing cascade. So this is referring to drug-induced illness. So let's say we start somebody on dihydropyridine, like amlodipine or felodipine. That can cause pedal edema. So then the prescriber starts a loop diuretic like furosemide, bumetanide, torsemide, and then that causes electrolyte derangements or incontinence. So now we're looking at more drugs. Do we do the potassium replacement? Do we put them on a drug for incontinence? So you can see where drug-induced disease can lead to more drug-induced disease. So we have to be mindful of that. What does the guideline say, particularly with the antihypertensives? So the American Geriatric Society Beers criteria says, oh, please don't use those alpha-1 blockers, and please don't use those centrally acting drugs. Clonidine is not a good player, and nobody should be on immediate release nifedipine anymore. The European said adults over 75 who you think are going to be gone in less than 3 months. The diuretics are of questionable value, excluding torsemide and furosemide, where you're trying to offload fluid. And they say you really shouldn't be starting an ACE inhibitor, an ARB, a peripheral vasodilator, or verapamil. And the following drugs are questionable to continue: alpha agonists and so forth. Don't continue a peripheral vasodilator. And they had no consensus about the rest that are listed there. Stop Frail says it's recommended to carefully reduce or discontinue antihypertensives with a systolic that is persistently less than 130. Now, it's one of my pet peeves when someone is on a beta blocker, like particularly a moderate to high dose of a beta blocker, and the prescriber orders, hold if less than this, the blood pressure, systolic or diastolic, or heart rate less than this. I don't think we should be playing peekaboo with a beta blocker because you don't want to stop it abruptly. So I would rather, if the patient has those days where their blood pressure and heart rate is trending down, let's just reduce the dose. And the Choosing Wisely campaign said don't initiate antihypertensives in patients over 60 with a systolic less than 150 or a diastolic less than 90. So it's kind of all over the place. So what about pulling the trigger? I do think it's important to evaluate comorbid conditions. So if someone has AFib, a beta blocker, or a non-dihydropyridine, may be beneficial for both. If they have heart failure, an ACE inhibitor or a loop may be also beneficial for both. I would gradually withdraw the beta blockers and any centrally acting alpha agonists. As a matter of fact, I always educate nurses that if you can't remember exactly which medications you can stop cold and which you should taper, my rule of thumb is anything that messes with your head or your heart, I would probably taper down. Now, of course, you could stop a diuretic suddenly. That's not going to cause any problems. But if you don't know, it's always good to taper down. And you always want to monitor for withdrawal effects, particularly if you're tapering down. So if you're tapering down a beta blocker and the patient develops angina or palpitations, or God forbid they have the big one, that's important information. Similarly for the other medications. So how would we have this conversation with Mr. Herndon about the antihypertensives? Hello. Mr. Herndon is experiencing side effects from his antihypertensive regimen right now. His blood pressure is low normal, and he's complaining of orthostasis. He says he gets really woozy when he stands up. So he's on both lisinopril and amlodipine. So maybe we could stop one. Also, he has lost 100 pounds, and people who have lost 100 pounds, their blood pressure goes down. So he's on a low dose of amlodipine. Let's just stop that one and sit tight and see how he does on the lisinopril. And I would bet chances are good we can probably reduce the lisinopril to 5 milligrams and then maybe even stop it and reassure the patients. Remember, we talked about that data. You've lost a lot of weight. Your blood pressure is trending down normally, even without the antihypertensives. And we do know that even if we stop an antihypertensive, there is this persistent beneficial effect. This says, I don't care about no stinking cholesterol. I guess if I was 4 to 6 weeks left to live, I'm going to say, go get the bacon cheeseburger. Absolutely. What about dyslipidemia? We certainly know that a high cholesterol or dyslipidemia increases the risk for ASCVD, leading to cardiovascular events, cerebrovascular events, and peripheral vascular disease. And we know that statin therapy or other drugs can slow or prevent the disease by reducing the progression or formation of atherosclerotic lesions. So the goal of therapy is to prevent morbidity and mortality associated with ASCVD. So again, heart attack, stroke, angina, need for revascularization procedures, peripheral artery disease, so forth and so on. So the time to benefit is at least a year or longer. So maybe it's shorter following an acute coronary event, but usually it's 2 to 5 years for protection against a heart attack. 2 years to impact all-cause mortality, and 4 to 5 years before you see protection against a stroke or TIA. So a recent meta-analysis showed a legacy effect, meaning the beneficial effect will persist on all-cause mortality and cardiovascular mortality, specifically in people using a statin for primary prevention. This is the study I just mentioned a moment ago about Gene Kuttner, looking at patients, 381 patients within a year of death. They were randomized to either continue the statin or stop it. The primary outcome is how many of these people died at 60 days, and there was no statistically significant difference. If you look at those who discontinued the statin, 20.3% died at 60 days, with the median time to death of 229 days. That's if they stopped the statin. Those who continued it, a little bit more died, 23.8%, and the median time to death was a little bit less, although those differences were not statistically significant. And I think this data from the Anglo-Scandinavian Cardiac Outcomes Trial is very compelling. They looked at, with atorvastatin, 8 years after the study was completed, evaluating the impact of atorvastatin. Even if everybody stopped the atorvastatin, the people who had been taking it had fewer deaths from cardiovascular and non-cardiovascular disease. What do the rest of the guidelines say? Stop-start has no recommendation for primary prevention. They say do start a statin for anyone with a history of coronary, cerebral, or peripheral vascular disease, unless they're end of life or over 85. Stop Frail says the risks are probably greater than the benefits for people who probably have less than a year to live. And there's no differentiation between primary and secondary. The heart people say primary prevention in people over 75 with diabetes, sure, continue the statin. Primary prevention in people over 75 who don't have diabetes, but their LDLs are above 70, maybe start the statin. And if they're over 75, it may be reasonable to stop the statin if they have functional decline, multimorbidity, frailty, or reduced life expectancy. And similar recommendations from the National Lipid Association. So what is the bottom line here? Primary prevention. We have conflicting data for people over 75 years old, but generally speaking, it's okay to discontinue lipid-lowering therapy in patients with a life expectancy less than a year or two. Secondary prevention, the evidence supports time to benefit is earlier in lipid-lowering therapy, and you should definitely continue the statin if they recently had an acute coronary syndrome, a stroke, or TIA, or they have unstable symptomatic disease. So there's no hard and firm recommendation on how recent is recent. Personally, I say if the patient's had a heart attack or stroke in the last 6 months, even if they're on hospice, I would say try to continue it until they can't swallow it all along. But these medications you can stop abruptly. So how do we have this chat with Mr. Herndon? Mr. Herndon, kudos to you for taking atorvastatin all these years. Clearly, it's been providing you with benefit because you've not had a heart attack or a stroke. But the good news is the research has shown the benefit you accrued from taking atorvastatin all those years was like putting money in the bank. And even if we discontinue the atorvastatin now, you will continue to reap the benefits. Research has further shown there is not an increased risk of a heart attack or stroke for people clinically similar to you. And while statins do not cause major side effects, it will be one less tablet you have to take and less risk of side effects such as muscle weakness. Okay, I have a whole talk called Give the Dying Diabetic a Donut. So what about his diabetes? Well, we know that diabetes is pretty darn prevalent. In 2019, it was over 11% of the population. And the kicker is, of the 37 million, only 28 million were diagnosed and the rest were undiagnosed. And then when you look at seniors, the percentage of people over 65 and older, it's about 29.2%. So that includes both diagnosed and undiagnosed. I think this is such impressive data. I'm sure everybody remembers the Diabetes Control and Complications trial from the early 1990s. They took people with type 1 diabetes and they divided them into 2 groups. Either people who had tight blood sugar control and they either had an insulin pump or multiple daily injections, and they met with their healthcare team like weekly, versus the other half of the people had their usual blood glucose control. And at that time period, it was usually like regular and NPH BID kind of dosing, and they met with your team Every 3 months, business as usual. And within these two groups, the tight control and the usual control, half of the people had no complications of the diabetes and half had early complications, as shown by nephropathy and early retinopathy. So in the people who had tight blood glucose control, they saw a 40 to 60% reduction in the development of complications in those who had no complications. And in those who already had early complications, they had much slower progression than the people who had usual control. Here's what's really interesting. If you fast forward 17 years after starting the DCCT trial, everybody who's still standing had pretty much equivalent blood glucose control now. But the people who had been in the tight glycemic arm still had a 42% risk reduction in any cardiovascular event and a 57% risk reduction in the risk of non-fatal MI stroke or death from cardiovascular disease. So in other words, this is the same thing of the benefit persisting. What does the ADA say? Well, if you're healthy, you really don't have any coexisting chronic illness, intact cognitively and functionally, they say, okay, maybe not an A1C less than 7, but certainly close to it, 7, 7.5. If the person is complex or intermediate, like maybe some multiple coexisting chronic illnesses, they're saying maybe an A1C less than 8. And then if someone's very complex or poor health, like an end-of-life patient, they say, you know what, don't even look at the A1C, just let it go. And just target a fasting of like 100 to even 180. Isn't that wonderful? And here, I'm not going to read this to you, but it just shows where the American Diabetes Association comes down on how strict we should be or not, depending on the patients. You can look at life expectancy. We should be less stringent if you look to the right, if they have a short prognosis. And again, De-Prescribing.org's got this wonderful two-sided card. I urge you to go to this website and download it and take a look. So let's look at his antihyperglycemic. So he's on metformin XR 1,002 tabs a day, Lantus at bedtime, and Novolog 4 times a day. Well, the metformin, this man has stage 4 kidney disease. He shouldn't even be on metformin. It is contraindicated in this man, so that needs to go. The Novolog sliding scale, he is checking his sugar like a doobie 4 times a day, but he hasn't needed it. As a matter of fact, he's had some hypoglycemia. And the Lantus, I think we need to consider what we know about diabetes and glucose control first, and I think we need to deal with the metformin and the sliding scale before we make a decision about the Lantus. So what does all this mean for Mr. Herndon? So again, all those years, he watched his diet, he took his drugs, he monitored his blood sugar, just like the blood pressure. It was like putting money in the bank. So now we can loosen the reins a bit and he can draw those dividends, secure in the knowledge that his risk of diabetes-related complications is very low, but we will monitor him carefully for symptoms suggestive of hyperglycemia. So what about the Lantus? Again, we're going to stop the metformin, we're going to stop the Novolog insulin for now. I personally think that poking somebody 4 times a day is not especially palliative. So why don't we back off on that a little bit, and maybe let's just check the fasting sugar 3 times in the next week or so. And you know, even if his fasting is up to 200, if he is asymptomatic, I'm okay with that. So we need to keep an eye on that fasting because that reflects the Lantus dose. So should we reduce the Lantus because it's trending, the blood sugar in the morning is trending down? We need to watch that. So, but stop checking the sugar 4 times a day. How do we have this conversation? Mr. Herndon, you deserve enormous credit for following your diet and your diabetes medication regimen for all those years. And like the statins, research has shown that tighter blood glucose control starting at the time of diabetes diagnosis leads to an accrued benefit in reduction of complications later in life. So you're not even using your Novolog insulin because your blood sugar isn't getting high enough to warrant it. And you have lost 100 pounds and you're not eating like you used to. So I'm thinking also, given your kidney disease, we really need to stop that metformin so you don't have any side effects. So I think we should stop the metformin and the Novolog insulin. Let's follow your blood glucose over the next week or so and make a decision about whether or not to continue the Lantus at your current dose or maybe even reduce it. And in the meantime, we can liberalize your meal plan and stop checking your blood glucose so frequently you have earned it. Now, if he does liberalize his diet, maybe he's going to need that whole 20 units of Lantus, but I think we have to kind of do a little seat of the pants dosing here. So how would we have this conversation? Which is the best response to Mr. Herndon? Sir, you are a few weeks away from death. Does it really matter what your cholesterol, blood pressure, and blood glucose are? Or B, you're not dying today, but within a month or so, it's really unlikely you're going to have a heart attack or a stroke, so I feel lucky. Or C, Clearly, you aren't dying today, but all medications have risks and benefits, and no medication is meant to be continued forever. And you start humming Let It Go under your breath. Or D, we'll take a look at each of your medications, and you and I and your family will discuss this with your doctor, and if it's hospice, and our doctor, and make decisions to give you the most benefit from your medications and cause the least harm. I do think conversations are hugely important in this kind of a situation. So obviously, D is the correct answer. Let's switch gears and talk about Alzheimer's disease. So we know this is the most common cause of dementia. 60 to 70% of 50 million people affected worldwide. It is not a happy diagnosis. It's a relentlessly progressive neurodegenerative disease. Average age of onset is over 75. We see worsening memory and declines in pretty much everything. We can see behavioral and psychological symptoms such as depression, anxiety, agitation, and so forth. The survival after diagnosis is about 4 to 8 years on average. So we all know people don't die of Alzheimer's disease. They die of something like aspiration pneumonia, for example. The goals of care are to try to slow the functional and cognitive decline and to maximize symptom control and the patient's quality of life. So how do we treat Alzheimer's disease? Well, certainly non-pharmacologic activity, such as we know now that physical activity helps prevent the development of dementia, and cognitive training, which is why I have a Sudoku puzzle for you to do later at your convenience, and certainly management of comorbid conditions. So what medications do we have that target Alzheimer's disease? Well, the most commonly used are shown here. The cholinesterase inhibitors, known as the cognitive enhancers, donepezil, ribostigmine, and galantamine, and the N-methyl D-aspartate receptor antagonist, memantine. And then somebody had the bright idea to combine donepezil and memantine into Namzaric. And we have aducanumab and we have lecanemab also, which I probably should add to the slide, but it's a pretty new agent. There was a third that went to the FDA, but they declined to approve it. And aducanumab has the reputation as being the worst launched drug in the history of marketing drugs, because a lot of people were very upset that the FDA even approved it. I don't see this drug really being used. Lecanemab, let's see. I think that probably is a more beneficial drug. So of course, we're going to look at a case. Here we have the case of Miss Judy. Miss Judy is a 78-year-old female. She's had repeated falls in the last 3 months. She's got a past medical history of breast cancer, high blood pressure, dyslipidemia, NVAF with no history of stroke, Alzheimer's disease, and she's a fast 7C showing 10% weight loss greater than, and a recent UTI. She lives with her daughter, Laura, here in Maryland, and the son, Frederick, who's a lawyer, lives in California. It's always the other adult child lives in California, and they're always a doctor or a lawyer or a nurse or something like that. So here are Judy's medications. She's on donepezil and memantine, lisinopril, atorvastatin, warfarin, a multivitamin, Ferrex, and the federally mandated calcium and vitamin D that everybody and their brother seems to be on. When you suggest, I think we can slim down on these meds, Laura, the caregiver, is on board, but Frederick, the lawyer from California, goes nuts, and he angrily says, "What is wrong with you people? Are you trying to kill her off?" "Yes, Frederick, you caught us. We're trying to kill your mother. You're too smart for us." Obviously, you wouldn't say that, but what are the issues here? Well, we have a lot of issues here. Let's look at the drugs first. The cholinesterase inhibitors, donepezil, galantamine, and ribostigmine, indicated for mild to moderate and moderate to severe Alzheimer's disease. Memantine, which is an N-methyl D-aspartate receptor antagonist, is only indicated for moderate to severe dementia. So I mentioned the FAST criteria that Judy is a 7C. To get into hospice, you need to be a 7. So it could be even a 7A, or it could be worse. So hopefully everybody listening right now is a 1 or a 2. And then it goes to early, mild, moderate, moderately severe, and then very severe dementia. So she is a 7C. Now, this is the study that everybody points to and says, "Oh my gosh, look, we can use these drugs right up to the bitter end." So, I said, I think I'm going to do a deep dive looking at this study. So Howard and colleagues took almost 300 community dwelling, moderate to severe Alzheimer's disease patients who had already been getting donepezil for at least 3 months and followed them for a year. They were stratified by study center. This is a multi-center trial. How long they've been getting donepezil, either 3 to 6 months or 6 months or more. Their baseline mini mental state score, either 5 to 9 versus 10 to 13, and their age. So they're randomized into 4 groups, either donepezil with placebo, memantine with placebo, both donepezil and memantine, or both placebo. So it's one drug, the other, both, or neither. Now, I really like how they set up their outcomes. They looked at two things. One is the mini mental state exam. So they said a clinically important difference would be if one group of people scores 1.4 points or greater than the comparator. And I really like the other measure that they use because we hear caregivers all the time say, I know it's not going to help her memory or whatever, but it's easier for me to handle her when she's taking the medication. Okay, great. Let's use the caregiver rated Bristol Activities of Daily Living scale. So this is a 0 to 60 scale. They decided that any group that scores 3.5 points or greater lower than the comparator would be a clinically significant improvement. So remember, the baseline mini-mental in this whole cohort of patients was about 9.1, 9.2. The baseline BADLS was about 27 to 29. So this is kind of a summary slide, again, reminding you a mini mental state score of 1.4 point increase or greater is clinically significant, and a BADLS of 3.5 points or more decrease is considered clinically significant. So when you looked at everybody who got donepezil, either alone or with memantine, versus did not get donepezil plus a placebo or memantine, the only one that made a difference was the mini mental state score was 1.9 points or higher. The BADLS did not make the cut for clinically important. And then when you looked at everybody who got memantine with or without donepezil versus nobody who got memantine, there was no difference. We did not achieve clinically significant differences by either outcome measure. And also the effect of donepezil and memantine did not differ significantly in the presence or the absence of the other medication. And donepezil plus memantine was no better than donepezil alone. So the take home here is when people are, pretty sick with Alzheimer's disease, the memantine didn't make any difference at all. Now, here's the money slide right here. When you do a sub-analysis and you break it down into those two subgroups where they stratified, people with a mini mental of 10 to 13, what was the impact of donepezil? It was 2.6. And remember, we only needed 1.4 to say that was clinically important. But the people who came into the study with a mini mental of 5 to 9, it fell short of achieving clinical importance. So only the people, donepezil was the only drug that made a difference, and that was only in people with a mini mental state score 10 or higher. I love this slide. I want to blow this slide up and wallpaper my bathroom with it. That's how much I love it. This is developed by Dr. Reisberg, who came up with the FAST criteria. So you look at the second line, the GDS and the FAST states. Remember, I told you we can put people with Alzheimer's in stages 1 through 7, and 7 we can break down even further. But if you look at stage 7, which is someone coming into hospice care, they have to be at least a 7A. And then you go down to the second from the bottom row, Reisberg says, if somebody's a 7, they probably have a 0 on their mini mental state score. Well, my favorite professor in pharmacy school had a sign in his lab that said, even a blind squirrel finds some nuts. So my point is, they might not be a 0, but you know what they're not? They're not a mini mental of 10 or higher. So just based on this evidence, these medications, when someone comes into hospice with Alzheimer's disease, are probably not providing any clinically important benefit. And these medications are not hugely damaging with side effects. Memantine in particular is fairly well tolerated. You can see dizziness, headache, confusion, and constipation. Cholinesterase inhibitors, I do think you see a fair amount of nausea, particularly with the donepezil 23 milligrams. That's kind of a backbreaker right there. So GI side effects. The one thing I do worry about is the cholinesterase inhibitors are highly vagotonic. So they have a vagotonic effect on the SA and AV node, manifesting as bradycardia or even heart block. So if you look at this data on the lower part of the slide, hospital visits for syncope, you can see the hazard ratio in people receiving a cholinesterase inhibitor was almost 2. The same for hospital visits due to bradycardia, 1.5 time increase due to result in permanent pacemaker insertion. And we even saw a statistically significant bump in hip fracture for people getting the cholinesterase inhibitors. So the bottom line, in my humble opinion, is the dementia medications are less helpful and potentially more harmful in advanced disease, meaning like a FAST-7. I do not think they are indicated or should be used or provided for a patient with a FAST-7 unless we see clear and ongoing benefit in managing identifiable and distressing symptoms. Now, this gets a little stickier when someone is admitted to hospice with, say, lung cancer, but they also happen to have Alzheimer's disease, but maybe they're a FAST-5 or 6. So I think that's a case-by-case decision. We have to have a discussion of the patient's goals of care, how they're doing on the medication, and so forth. If you choose to stop one of these drugs, I would definitely taper down The De-Prescribing.org website has a beautiful whole section on these medications from the University of Sydney. So Laura is on board with what you're talking about, but is Frederick buying what you are selling? No, he is not. So I do think it's very important that we really kind of practice having conversations. So people always say, oh, you're a pharmacist, you don't have to break bad news. Oh, the heck I don't. So when I'm talking to a family member about stopping mom's drugs for Alzheimer's disease or stopping the Rilutech for ALS, sometimes they're not very happy. So I like using this SPIKES protocol. So SPIKES, what is this? First, S, setting up the interview. When you have this conversation, you want to do it in a relatively private, confidential area where you can support, if it's the patient, but in this case, probably it wouldn't be, it would be the informal caregiver. Also perception, what do they already know? What has your doctor told you about these medications and what they're supposed to do? And is it still working for your mom? Or when should we stop it? Also invitation, can I share some information with you? Can I share my thoughts with you about this medication? Do you want to know? Sometimes they say no. Well, then you got to pack up your dog and pony show. But most people will say, sure, I'll hear you out. So then you provide some information. And I just gave you the information. Sometimes I will say things like, okay, riddle me this. How was your mom a year ago compared to right now? And you'll hear things like, oh, well, a year ago, she knew who I was and she could walk up the stairs by herself. So then you could say, so despite being on these medications for the last year, you're telling me your mom has declined. Yeah, she really has. So here's what the data says, that by the time someone is in your mom's situation, a fast 7, these medications likely are not providing any benefit, but in fact raise the risk of having a side effect. So I'm very concerned about that. And then when you lay that on them, many times you'll see an emotional response. So I think the most important thing in the world we can do is to be empathetic. That doesn't mean you necessarily agree with them. But if Frederick's having a meltdown saying, oh my gosh, this is the medication that slows this awful disease, and if you stop it, my mom's going to drop dead tomorrow, to say, I could see why you're upset by that. But again, let me provide some information to you that often we have found that stopping these medications, people actually get a little bit better because it seems sometimes like their behavior improves. But here's what we do by tapering down. If we go down a little bit on the drug, if things get way worse, we'll go right back up to where we were. So really talking about this strategy, summarizing, and what is your plan for follow-up? So what do the guidelines say? The Beers list say, watch those cholinesterase inhibitors. Don't use them in old people due to the risk of bradycardia. Stop frail, no consensus on the cholinesterase inhibitors, but memantine, they say, you know what, let it go, unless they really, really have seen improvement in their behavioral symptoms. The Europeans said, if the prognosis is less than 3 months, again, let it go. The Australians say same thing. If they've been getting the drugs for at least a year, but still had worsening of disease or no benefit noted, or it's end stage. And again, by tapering down, and these are the guidelines from Australia on the de-prescribing.org website, they have a lovely table saying, if you're tapering down or stop these medications and then behavior gets worse, it depends on when the time is, like is it 3 days after you cut the dose, or is it 6 weeks after you stop the medication? Really, really excellent. Good guidance there. And the Choosing Wisely American Geriatric Society says, you know what, those cholinesterase inhibitors used for over years, not sufficiently been studied. So if you don't see an improvement within 12 weeks, I probably would stop them. So again, I really like what they did at the University of Sydney. You can either go directly to their website where they provide evidence-based recommendations and consensus-based recommendations and practice points. And here is the front and back of the card that they have on the cholinesterase inhibitors. And there's even more information on the website. So my conclusion from this presentation is I think we all need to be mindful of the prescribing continuum. So for example, if your doctor, nurse practitioner, PA told you, you've got high blood pressure, and it doesn't seem like the diet and cutting out the salt has really helped. So I think we need to start a little HCTZ. What do you think about that? You would probably say, okay, let's go ahead and try 25 milligrams and see how it does. So, your provider's going to evaluate you or the patient we're talking about. They're going to consider things about you as a patient, like what's your kidney function, what's your liver function, what are you pregnant, are you breastfeeding, whatever. They consider patient and medication specific variables and make the best decision. What's the best drug for this patient? You in this case. So then you try it, you start taking the HCTZ, Maybe your provider has to bump the dose up a little bit, possibly, and they're monitoring your response to therapy. And let's say 3 months in, they say, you know what, this is just not working. It is not meeting the goal, and increasing the dose is not going to do any good. So we'll either add a second drug, or why don't we just stop the first drug and we'll start the second drug. So, you're probably not going to cry about it. You're going to be like, well, that's interesting. It didn't work, but sure, let's go ahead and switch to a new drug, and hopefully that will get the job done. But the stakes are so different in advanced illness. We're not just talking about a little hypertension. This is literally life and death. So we really have to take this seriously. But as prescribers and people who follow medications, we have to weigh the benefits and burdens of drug therapy in all patients, but especially in advanced or serious illness. And I do think the conversations are most important. I'm working on a book on goal concordant prescribing in serious illness with some colleagues, and we have a whole chunk for every medication group on how to have those conversations. Well, that concludes my comments, and I'm going to turn it back to Lauren.
Thank you so much, Dr. McPherson. We did have one question come through the chat, and I encourage if anyone else has a question, we do have a couple minutes, so please feel free to chime in. The question in the chat box, Dr. McPherson, is for a patient with a serious advanced illness, what blood glucose level or A1C should we target?
That's a great question. As I shared with you, one of the guidelines said, look, don't even worry about the A1C at this point. The overarching goal with someone with an advanced illness is to keep them comfortable. So I know that if someone was diagnosed with diabetes, they would say, let's keep the fasting between, 70 and 110 at this point, because you're in, the prime of life. But someone with an advanced illness, I would say, don't even bother with the A1C. And I would target a fasting, as we saw from the ADA, up to 180, maybe even 200. But the most important thing is to know the symptoms of hyperglycemia and to monitor for those.
Thank you, Dr. McPherson. Thank you. I don't see any other questions in the chat box, but certainly if something comes up, please reach out and we can get Dr. McPherson to help us out with those questions for you. So thank you again, Dr. McPherson, for this presentation on a topic that may be relevant for many. And thank you to everyone who has joined us today. We hope the information was useful to you. Join us as we celebrate 44 years of partnerships and excellence in care of the Lower Eastern Shore. In the frame of our 44th anniversary, Coastal Hospice invites you to honor these partnerships. Please visit our website to vote for the nominees and celebrate with us by attending and sponsoring our first Excellence in Quality of Life Awards. To wrap things up, we ask you to take a couple of minutes to fill out a short survey. By filling out this survey, you will allow us to continue to provide continuing education credits to you via email, and your feedback will help us bring relevant programs to you, your practice, and those you care for. To complete the survey, visit the chat box. You'll need to click on the appropriate link for your field or scan the QR code on the screen now. You will be able to print your certificate of completion immediately after completing the survey. Additionally, you will receive a follow-up email later today containing the links to the surveys. Please remember that you will need to fill out the survey within 24 hours in order to receive the continuing education credits. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community at Coastal Hospice. We are here for you, and you can call us at any time on the number on the screen. Thank you once again for joining us. I'm Lauren Blair. Have a wonderful rest of your day.